Great. All right, everyone, welcome. It's so great to see all of you here today. This third part of our Dysautonomia series today is talking about exercise and dysautonomia with Dr. Dibble from the University of Utah. I am Nancy Barlow. I'm the wellness coordinator at Parkinson's Resources of Oregon. And just if you haven't attended these, Parkinson's Resources of Oregon has been helping people with Parkinson's for over 40 years. We're a local nonprofit organization that serves Oregon and Southwest Washington, providing support services, education services, advocacy services. So welcome again, and I'm going to introduce Jean, sitting right next to me. Jean is one of our clients who has battled a little bit with dysautonomia and figuring out what it was and how to deal with it, and she is going to introduce Dr. Dibble today.
Thank you, Nancy. When looking for a speaker for this topic, I found that Dr. Dibble stood out as especially qualified due to the breadth of his experience and the depth of his research in neurodegenerative diseases. Furthermore, he was very generous in agreeing to be part of our series. Dr. Dibble has held a variety of positions in the physical therapy department at the University of Utah for over 15 years, where he currently serves as chair. These positions include clinical, teaching, administrative, and research responsibilities. Dr. Dibble's educational background includes a BS degree in animal physiology from UC Davis, an MS degree in physical therapy from Duke University, and a PhD in exercise and sports science from the University of Utah. Clinically, Dr. Dibble has worked as a certified athletic trainer and as a licensed physical therapist, including such venues as the Olympics in Salt Lake City in 2002. Don't be deceived by his obvious youth. Dr. Dibble is much sought after as an expert in the field of neurodegeneration. He's internationally known for his research on the progression of disability as well as the benefits of exercise. Also, he has served as a recognized leader among his peers, having produced approximately 200 scholarly works. And in 2017, he was chosen as a member of a panel of experts that included neurologists, movement disorder specialists, and physical therapists to develop a gold standard of exercise to recommend for people with PD. So it's with great pleasure I welcome Dr. Dibble today. Thank you for being here.
Thank you. Thanks for that introduction. I think that makes me feel like I don't sleep enough, and I need to get other hobbies besides work.
Clearly.
You're not supposed to agree with me. Moving along, I obviously created some slides for the presentation, but I want to make sure that it all meets all of your needs. So I would encourage you to put questions in the chat, and I'll do my best to answer those once we kind of get through everything. So I know that the talk is supposed to be on autonomic dysfunction in Parkinson's disease, but I kind of focused it a little bit more, and that is cardiovascular autonomic dysfunction, because that is probably the most relevant component of autonomic dysfunction that impacts exercise and clinical practice. Make sure there we go. So I've gotten in the habit when I do presentations to acknowledge individuals that we work with and the funding agencies at the start of a presentation, because I couldn't do any of the work that I do without funding from grant organizations or the colleagues that I work with. And so before going on, I just need to acknowledge people that I work with at the University of Utah, the participants and people with Parkinson's disease that have taught me a great deal. The neurologists that I work with that are listed there, two in particular, the third and fourth bullets down there, Guillaume Lamont and Melissa Cortez are, I would credit with kind of helping increase my knowledge of autonomic dysfunction. They are both neurologists that are trained specifically in autonomic disorders. In fact, they did their fellowships with Dr. Goldstein at NIH. We also have colleagues that I work with at other institutions. most currently, Jay Alberts and Anson Rosenfeld at Cleveland Clinic on an ongoing exercise trial in Parkinson's disease, and then Dan Korkos at Northwestern University, who, along with others, helps run the SPARKS-3 trial, which we're also involved in. And I know OHSU is involved in that trial also. We've had the good fortune of having funding from NIH, the Davis Phinney Foundation, the Parkinson's Foundation, and Michael J. Fox. So what I wanted to do is go over a number of objectives, and my hope is that we accomplish all these objectives over the course of the time that we have together, discussing the origins of cardiovascular autonomic issues in Parkinson's disease. I really want to emphasize how both posture changes, so moving from, say, lying down to standing up, and physical activity are both challenges to the autonomic system, and how those might be affected in people with Parkinson's disease. Hopefully provide a little bit more detail about how we interpret clinically signs and symptoms that could indicate cardiovascular autonomic dysfunction, and then talk about strategies for addressing cardiovascular autonomic dysfunction with exercise and other non-pharmacologic strategies. So I'm going to start with going into an overview and relevance and definitions, talk about generally about the cardiovascular autonomic response to posture change and exercise, and then talk about clinical management. But before I do that, I need to kind of talk about the caveats. You all asked a physical therapist to come and give this talk, so I need to pre-admit my bias. I have a biased view of exercise. I'm a physical therapist. If I didn't believe in the value of physical activity and exercise, what kind of PT would I be? And then kind of based on that, I believe that clinical problems are best managed through a combination of treatments, and that includes non-pharmacologic and pharmacologic. Now, I'm not an MD, so virtually nothing in the talk that I'm giving to you today is going to talk about pharmacologic management. Please don't misinterpret that. That does not mean that I'm going to, that I poo-poo the idea of pharmacologic interventions. I think it's valuable and important component. And I had the opportunity to watch some of Dr. Goldstein's presentations that were on YouTube that he had given to all of you. And I know that he covered some aspects of pharmacologic management. And then I also would say that based on our clinical experience over a few decades now, that we believe that some degree of autonomic dysfunction is present in the majority, if not all, of people with Parkinson's disease. There is obviously a variation in the intensity of those symptoms, but I think that if you look closely enough, you would find it in the majority of individuals. So if we then focus specifically in on autonomic dysfunction and Parkinson's disease, it sits within this kind of realm of what we call non-motor issues. I think the general public thinks of Parkinson's disease as tremor and shuffling of gait, some balance problems, things like that. But so those are the readily identifiable motor abnormalities or challenges with Parkinson's disease. But then there's these non-motor. And in this context, I actually don't like that term. Within anatomy, we talk about kind of skeletal motor, meaning the muscles in your biceps and your triceps and your quads. And then we talk about visceral motor, meaning the muscles in your blood vessels, your heart, your GI tract that are kind of visceral motor. So I view autonomic dysfunction in Parkinson's disease to be a somatic motor and a visceral motor issue. And I put in a box here on this image, the thing that I wanted to focus on talking about today is cardiovascular dysfunction, meaning what happens from a heart rate and blood pressure standpoint in the context of Parkinson's disease, or what could happen. And I wanted to emphasize why we're talking about this, that individuals with Parkinson's disease that have some degree of cardiovascular autonomic dysfunction have an increased incidence of falls, and that could be from fainting. There's increased healthcare utilization, so there's more costs associated with individuals that have cardiovascular autonomic dysfunction. It adversely affects activities of daily living like walking, moving around in your environment. And there is some data that supports that just thought processes, executive function, memory, other things can be affected adversely. So we think it's an important thing to pay attention to and address. So you've probably heard of this term orthostatic hypotension. And I'm going to kind of broaden that kind of conversation a little bit. So I want to talk about orthostatic hypotension, and then also use a term called orthostatic intolerance. And that reflects generally a drop in blood pressure when a person goes from lying down to standing up, that the blood pressure decreases. The American Academy of Neurology defines orthostatic hypotension as a drop of 20 millimeters of mercury of a systolic blood pressure, or 10 millimeters of mercury for diastolic. But that doesn't always correspond to symptoms that an individual has. We have some individuals that come into the clinic and drop 10 millimeters of mercury systolic and have symptoms. They feel like they're might pass out. And we have others that drop 30 millimeters of mercury and say they're feeling fine. So there is a diagnostic criteria for orthostatic hypotension, or that drop of blood pressure when standing. But our feeling is that some people could be orthostatically intolerant. They might not drop that much, but they still have symptoms from an alteration in blood pressure. Two other things on this slide to kind of really emphasize is that the drop in blood pressure is thought to be an impairment in a particular kind of vascular reflex that it involves the heart and the arteries. And one of the things that we're going to talk about more as we go along here is that orthostatic hypotension intolerance, as I said previously, might be present in the majority of individuals with Parkinson's. But I want to broaden your kind of awareness of this potential symptoms. And then we're going to kind of specifically talk about two kind of subcomponents: neurogenic, that might have an origin in the brain or nervous system, and then non-neurogenic orthostatic hypotension or intolerance. I put the outline slide in here again to make sure that I don't pick up too much speed in terms of talking. So just take a pause. I'm going to take a deep breath and then move on to talking specifically about cardiovascular autonomic responses to posture and exercise stress. I'm not trying to stress you out in terms of anatomic images here. One of the things I wanted to emphasize here with this image is that you've got the heart there on the right-hand side of the page. The heart's pumping. There actually are in the aorta and in the carotid arteries, there are pressure sensors that are responsible for sensing what your blood pressure is. If there's alterations in that, it's sent to your brainstem specifically. And if there's problems, in the blue lines on this anatomic image, there is neural discharge that comes out of the nervous system and goes back to the heart and tells it to either speed up or slow down. Those signals also go out to the heart or out to the blood vessels and change the caliber or the constriction ability of those blood vessels. To kind of talk about how it functions in two different cases: hypertension or high blood pressure, the stimulus to those receptors in the aorta and the carotid arteries. If there's a rise in blood pressure, the response that the nervous system sends out decreases the heart rate and then increases the caliber of the blood vessels. They go from smaller to larger, and that decreases the blood pressure. More relevant to what we're talking about today is on the right-hand side of the image, and that's hypotension, meaning reduced blood pressure. So the stimulus is a drop in blood pressure that those receptors sense, and the nervous system hopefully elicits a response that causes the heart rate to increase and the vessels to go from larger to smaller, that vasoconstriction brings the blood pressure back up. That would be the arterial baroreflex working actually the way you hope it does, or it's supposed to. So let's talk about what happens then in the context of a postural stress. So the person in the middle of the page on the left is lying down. There's plenty of blood kind of in the abdominal cavity, and more importantly, kind of in the chest cavity that can be pumped up to the brain. Person stands up and gravity pushes the blood down, or kind of preferentially keeps the blood in the lower extremities. So the central blood volume is lower. Ideally, what happens is that the aortic arch and the carotid sinus sense that, and they go ahead and elicit a response that causes vasoconstriction, or the arteries to get smaller and the heart rate to speed up, and therefore you get blood flow to your brain and you don't pass out. One of the kind of jokes that we make is that fainting is the body's defense mechanism about how it makes sure that the brain gets blood flow. If you stand up and your brain doesn't get blood flow, you faint, and then your head gets lower and your brain then gets blood flow. So we don't want to get to that point. What I'm describing here is normal kind of physiology in terms of response to postural stress. So key point here is that the arterial baroreflex, that kind of vascular reflex, adjusts the heart rate and the blood vessels to maintain blood pressure and blood flow to critical areas. When I say critical areas on these slides, you should probably read that. I could change it to be your brain, because you want to make sure that you kind of you get cerebral blood flow that keeps things working the way they're supposed to. So I talked about postural stress being a one stressor to the autonomic system. The other autonomic system or the other stressor to the autonomic system is physical activity. And in this case, you can see on the kind of left-hand side that arterial baroreflex is involved. But there are a number of other systems that are involved in the black arrows. Signals from your brain, signals from your muscles, signals from your heart are all kind of sending signals to your brain, to the brainstem, and that then creates the signals that keep your heart and blood pressure, heart rate and blood pressure appropriately tuned to the workload of your physical activity. So the key point here is that the arterial baroreflex, besides responding to postural stress, regulates blood pressure during exercise based on the intensity of what you're doing. And it adjusts that based on the heart rate and contractility and the blood vessel adjustments in terms of constriction or dilation to maintain blood flow, particularly to your brain. If we consider people without Parkinson's disease and what the effects of exercise training are on autonomic function, there's clear kind of evidence that supports that chronic exercise or physical activity improves the sensitivity of that reflex I was just describing. It also, at rest, decreases the activity of that fight or flight system. So it decreases sympathetic tone. It increases kind of the rest and digest kind of part of the autonomic system, so the vagus nerve. So there are positive benefits at rest, and there are positive benefits with exercise. And again, this is in the context of individuals without Parkinson's disease. So there's clear evidence that exercise improves autonomic function. And just to kind of give you additional evidence of this, I wanted to show you a graph of exercise and autonomic function. My habit here is to orient people to what we're looking at prior to kind of jumping into the results. So on the y-axis of this graph, the vertical line, it says cardiovagal and that's baroreceptor sensitivity. And in this case, on that y-axis, higher is better. On the x-axis here, you have 3 different categories of exercise, amounts of exercise that people do. There's a sedentary group, there's a moderate exercise group, and there's an endurance trained group. And within each of those categories, there's a Y for young, there's a middle-aged group, and there's also an older group. Hopefully you can see, let's look at the sedentary kind of grouping there, that there is clearly an effect of age on baroreceptor sensitivity. But interestingly, if you go from the sedentary to the moderate exercise kind of group of graphs or bar graphs, you see that if a moderately exercising middle-aged adult participates in exercise, they preserve their baroreceptor sensitivity. So their cardiovascular function is better because they've kind of participated in exercise. And even if you go to endurance trained, you can see that. So there's clearly an effect of exercise, and it partially counteracts the effects of age. So the key point in this graph, again, was that exercise improves measures of autonomic function regardless of age, but that age does have somewhat of an effect. So I'm focusing predominantly on the orthostatic hypotension component of cardiovascular autonomic dysfunction. I just want to at least make a statement that there are other aspects of and measurements we could take, but those are harder technically to measure. So we're really kind of focusing more on the orthostatic hypotension component, because that's oftentimes what people, when they come into the clinic to see a provider, are complaining about. So moving forward and talking for the remainder of what I was going to say is I want to just really emphasize the fact that in many cases we're talking about people with Parkinson disease and then beginning to think about exercise, that there's 2 concurrent stressors to the autonomic system, and that is changes in posture, going from laying down to sitting to standing, which stresses the autonomic system. And then in addition, there's a physical activity and exercise-based stressor. So anytime that a person is doing upright activity and doing exercise, there's 2 stressors that the autonomic system has to deal with. So let's talk about individual with Parkinson's disease response to postural stress. I'm going to talk about the top graph first, which is a normal response, meaning a non-neurogenic orthostatic hypotension response. Blood pressure is on the y-axis here, heart rate's over here, and that's actually the green line is heart rate. So starting at it's around 80. Systolic blood pressure is the top part of the red. Diastolic blood pressure is the bottom part, and then minutes are on the x-axis. You can see that right here where the arrow occurs, the person went from lying down to standing up. There was a drop in blood pressure, but the arterial baroreflex worked the way it was supposed to, and heart rate went up, and the person did not have any problems with fainting, the feeling that they were going to faint. Now that's in sharp contrast to what's on the bottom here, where person's heart rate is about 80. At approximately 5 minutes, the person went from lying down to upright. There was a significant decline from 160 millimercury systolic to somewhere in the order of 80 systolic. So that clearly meets the definition of orthostatic hypotension. And unfortunately, you don't see any response of the heart rate. So that is a person that I think you may have heard the term when Dr. Goldstein talked. That is a person with neurogenic orthostatic hypotension, meaning that the blood pressure dropped, the heart rate didn't respond, and this person very well could have passed out during that test. in terms of cardiovascular regulation during exercise, I'd love to tell you, come and tell you that we have great data to support the regulation, our understanding of the regulation of cardiovascular function during exercise, and particularly autonomic function. That's not the case. We're conducting some of those studies now. Guillaume Lamont is working on those. Another one of my PhD students, Aaron Sutman, is also working on trying to get better understanding of that. On this image, I really want to emphasize that we know that arterial baroreflex is affected from the postural studies, but there may be effects of other systems. But I also drew those X's purposely smaller because there is an opportunity for other parts of the nervous system to compensate for problems with the arterial baroreflex. And one of the things we may try to do with exercise training is exploit those other systems to see if they can help address some autonomic dysregulation. One of the things that people may feel that have autonomic dysfunction with their Parkinson's disease is some degree of exercise intolerance that may manifest itself as fatigability or symptom provocation, and it may compound, it may potentiate or conspire with deconditioning to just make function worse. And to kind of wrap up what I just talked about with regards to postural stress and autonomic stress, that Parkinson's disease may impair response to autonomic stressors, and that includes the postural stress and physical activity. So now I want to move on to talk about what we might do about that from a clinical standpoint. One of the key points here that I wanted to cover is that in terms of talking to your provider and the PT listening to that, we have to listen for more than just a complaint of lightheadedness, and there are other symptoms that may be indicative of autonomic dysfunction that aren't really that kind of feeling like you're going to faint. Here's the kind of classic definition in the literature right now of symptomatic orthostatic hypotension. That's that lightheadedness, feeling faint, or I feel like I might black out. And then there's this whole list of inappropriately named asymptomatic. I mean, the fact that you're saying it's asymptomatic and then there's a big list of things underneath it doesn't make sense. We actually kind of want to kind of rename that, cross it out, and it should probably be differently symptomatic. So is there lower extremity weakness or buckling? Is there some cognitive effects, some confusion or disorientation or unsteadiness or fatigue? Dyspnea, sorry, I left that word in there, kind of shortness of breath. Is there head or neck pain? Is there urinary symptoms? There's a variety of symptoms that could be ascribed to autonomic dysfunction that are differently symptomatic and not the classic, I feel like I'm going to faint. So we're asking the PTs that we train and the PTs that work in our clinic to pay attention to that, and actually individuals with Parkinson's disease to also pay attention to those symptoms that could be indicative of autonomic dysfunction. So here's some screening questions that we might use. The blue ones represent kind of the classic symptoms, but then look at the other ones: visual disturbances, difficulty breathing, leg buckling, leg weakness, neck pain, then questions about posture, questions about worsening after meals. So there's a variety of questions. And the last bullet is also not just immediately upon standing, but what happens if you've been up for a long time? Do you have symptoms that don't come on right away, but they come on within 3 or 5 minutes? All right, I left the animations in there. The other questions that we want to know from individuals are, obviously, does posture change their symptoms? but what's the effect of temperature? Does high heat, like going in a hot tub or being out in a hot, humid environment, does that affect you? What about dehydration? What about large meals or alcohol intake? What medications might a person be taking? If they're taking blood pressure medications, that may affect overall function. And then what's the effect of, bearing down or coughing? The Valsalva is that kind of increasing your intra-abdominal pressure. Does that at all affect what your symptoms? As a physical therapist working with individuals that might have this problem, one of the things we're trying to kind of tease apart is what are the contributions of the nervous system, so that neurogenic orthostatic hypotension, and what are the contributions of other factors. So heart rate and blood pressure being affected, but not by neural structures. So is there an effect of blood volume or dehydration or blood sugar? And if you think back to what I talked about when I first started and admitted my caveats, in virtually all cases, we feel like any clinical presentation is the combination of nervous system and non-nervous system kind of contributions. So if I had to write out and sketch out on the back of a napkin how we were going to try to address people that might have autonomic complaints or orthostatic hypotension complaints, we would use these kind of 5 treatment categories. And notice that neurogenic and non-neurogenic orthostatic hypotension are up there, but the intervention doesn't dramatically change. And true to my form and my bias, I'm a physical therapist, so I'm going to spend the majority of the time from this point forward talking about exercise. We are strong advocates for minimizing the stresses that the autonomic system has to respond to. So I said earlier that posture changes and exercise are both stressors to the autonomic system. So one of the things that you could do to make a person's symptoms worse is have them stand up quickly and then start to exercise right away. You've changed posture and you're creating physical activity demands. That's not the recipe for a person feeling good and having good exercise tolerance. So one of the things that we're asking individuals to do is start an aerobic exercise program, or we're prescribing that, and we're trying to minimize the postural stress to begin with. So we're very big fans of recumbent steppers, probably even over recumbent bikes, because as you notice the picture on the left, that the woman on the recumbent stepper is using both her arms and her legs. So all large muscle groups associated with all 4 extremities, which has more of a kind of overall benefit than just pedaling with your legs like the individual in the middle. I'm more of a fan of the leg press type of activity on the upper right of the image, where the woman doesn't have to lay down completely flat. They're laying down flat kind of would minimize some of the postural stress, but I'd like to provide a little bit of stress, and you can adjust that over time. And the image on the bottom right certainly is a way that you could minimize postural stress too, but getting on and off that piece of equipment might be challenging for some individuals. If we're talking about what aerobic activity we'd have people do, the recumbent stepper or the new step, we're utilizing that scale on the upper right. It's called a rating of perceived exertion, and we're looking for that somewhere in the yellow, probably in the middle of the yellow, that 13, somewhat hard. You might be able to talk, but you feel like you're working, and trying to avoid the symptoms that might be associated with autonomic dysfunction. And from a goal standpoint, we're shooting for 3 to 4 times per week, moderate intensity, 20 to 30 minutes. We may not be able to get there to start with. So smaller bouts that might be lower intensity, trying to add up to 20 to 30 minutes, maybe the thing that you have to start with. If I had to pick a bias of different types of exercise, based on our research, I'm more interested, I am in resistance exercise. I think both aerobic and resistance exercise are important, but here's some examples of some types of resistance exercise that a person could do. Bridging, which is pictured here, but the leg presses, ankle pumps, and knee extensions, chest press. Notice that there's a progression from laying down to sitting types of activities. And at least here, I haven't bothered to go all the way to standing, because philosophically, we're still trying to do the exercise while by gradually progressing the postural stress. So that was kind of the exercise component. But I would also say that we want to try to maximize the ability of the rest of the physiologic system to augment the exercise effects. So we do ask individuals to consider maybe some compression type of socks like a runner might wear. I know Dr. Goldstein in his comments wondered if those worked or not. I don't know. It's hard when we ask a person to try to address this. We kind of throw all of these things at them, so it's hard to tease out what works and what doesn't work. But oftentimes, individuals that would come to our clinic would get a recommendation for some compression socks. Hydration, making sure that you're maximizing hydration. Spreading out meals throughout the day as opposed to a big kind of meal that sits in your stomach and could affect blood pressure. Starting the day with a lot of water, and then making sure to be conscious of the effects of temperature, because overheating causes dilation of the blood vessels on the skin and decreases the overall blood pressure throughout the body and increases the risk of somebody passing out. So in terms of concluding what we're talking about, I would say that autonomic issues in people with Parkinson's disease are present. I'd go so far as to say the majority of individuals, and they're specifically clinically relevant. That individuals that change their posture or change their physical activity, going from rest to activity, both of those changes require the autonomic system to drive the heart rate and blood vessel response. And if you put both of those stressors together in a person that might have a little bit of a problem with autonomic function, that might be the recipe for symptoms that could adversely affect them. Exercise training, in my opinion, improves autonomic function, certainly in people without Parkinson's disease. And our clinical experience and some limited evidence suggests that it does do that in people with Parkinson's disease also. From a clinical standpoint, we want you and we want our clinicians to recognize symptoms so that they understand when they might be having that. That a focused type of exercise that minimizes postural stress and then gradually layers in physical exertion, and then addressing aggravating factors like hydration and timing of meals and other aspects will optimize the non-pharmacologic management. I would go back to something I said at the start, that optimal treatment for any individual is likely the combination of non-pharmacologic and pharmacologic management. So as promised, I did not focus anything on medications within the presentation. That please do not misinterpret that. I'm not advocating that you don't address or talk to your medical provider about potential pharmacologic management for symptoms also. I think another thing that I didn't mention at all before I kind of stop for questions is we're still trying to understand the role of dopamine replacement medications, things like Sinemet and dopamine agonists, and their role on all of these symptoms, because we know that dopamine related medications may have some activity on the blood vessels. And so that could, although helping skeletal motor function and movement capabilities, it may adversely affect cardiovascular responses. And so it's a balance for people taking the medication. What benefits are they getting and what adverse symptoms are they getting? I had the good fortune to go visit my father-in-law who lives in Hawaii a couple of weeks ago. So some people's in-laws happen to live in very cold places in the wintertime. My in-law does not. So I took this picture when the moon was full. That was the day that it wasn't raining sideways. But, so I had,
That's Hawaii in the winter, huh?
yeah, seriously.
Still nicer than some places on the mainland.
Yeah.